I appreciate the invitation from the IPDI CARDIOCON 2022 from the Bangladesh, and I'm enjoying your presentation. I am delighted to hear from Professor Jamaluddin, Mir Jamaluddin, regarding the distal axis. We all been learning through the new technique of that. What I'm presenting today, and I'm thankful for the chairpersons and also the panelists, is a transradial chip PCI. It may not be a slender PCI because only select patients can be carried out with a slender PCI. Um, Slender PCI. So what I'm doing, presenting is a complete revascularization of coronary artery disease, a multivessel coronary artery disease involving the left main and RCA for what was considered a no-option coronary artery disease. So this is an OCT guided rotablation and a shock wave lithotripsy for a chip multivessel PCI involving left main, LAD, circumflex, and RCA. And because of that, we have coined the term rototripsy with rotablation and lithotripsy. We all know that the angiography is a poor indicator of the calcium, which is a significant impediment and deterrent to delivery of balloons, and possible predilatation may be inadequate. And therefore, most of the situations where there is a dense and heavy calcium, it can lead to stent underexpansion, asymmetric stent expansion, malacquisition, which has a significant bearing on the immediate as well as the long-term results. We know that the early and late stent failure is always due to the underexpansion or an inappropriate size stent. So if the MSA of the stent area is less than 4 square millimeter, you define it as an underexpansion, and there's a significant neointimal hyperplasia and restenosis within 1 year. And also beyond 1 year, you would see that if the MLA is less than 4 square millimeter, indicating a poor expanded stent, it definitely causes a late stent failure as well. So the patient in consideration is a 76-year-old gentleman, diabetic, hypertensive, hypothyroidism, dyslipidemia with a CKD and EGFR of 58 ml per minute. He had an end-STEMI anterior wall in January 2019 with pulmonary edema. At the time, his ejection fraction was 32%. His angiogram was done elsewhere in 2019 and shown to be having a heavily calcified left main and 3-vessel disease. And 2 cardiothoracic surgeon opinion, they rejected, saying that target vessels are unsuitable for bypass grafting. So he was continued to be on optimal medical treatment and heart failure medications, and the ejection fraction improved to 50% from 32 in 6 months' time, and he was in NYHA class 2. Subsequently, he had acute pulmonary edema, end-STEMI in February 2020, and a year later, and ejection fraction again came down to 36% with pulmonary artery hypertension, and therefore the repeat angiography and chip PCI revascularization was proceeded, as the cardiothoracic surgeons had already denied any CABG surgery. So you would appreciate that this is the angiogram of this gentleman, which shows a heavily calcified, so very short left main, heavily calcified mid-circumflex and proximal circumflex, diffusely diseased OM vessels, heavily calcified proximal to mid-LAD and distal LAD vessel. And the RCA is very, very poorly perfused because of the intense level of heavy calcium. So because of these reasons, the surgery was denied for him. And as a stage 1 PCI under conscious sedation, a temporary pacing wire was kept in the right femoral vein, and then a right radial approach was a 6F EBU guide catheter. Initially, the rotor extra support guide wire could not cross. You could see the rotor extra support guide wire is buckling here, and a Fielder XT wire was used, which has a tapering 009 tip, and therefore that could cross with a balloon support, or rather a microcatheter caravel support. And then I used a 1 mm balloon to dilate at the tightest point where the wire was finding it difficult to cross, and then again kept you could see the 1 mm balloon dilatation here. Then introduced the caravel after docking the wire and exchanged through the caravel the rotor extra support guide wire, which you can see here, and the rotor wire could be delivered there. Subsequent to that, 1.25 mm rotor ablation was done. Rotablation was done at 170 RPM, and from proximal to mid-LAD and mid-LAD to distal LAD was done, and you could see that there is no perforation and there is no dissection in the tightest point of the calcification. This was followed by IVL of 12 mm. I will come back to the OCT images. This is a 2.5 into 12 mm shockwave lithotripsy balloon to apply to the mid LED and also the proximal LED. And post, you could see the panel 6, the image is showing a very good luminal gain in the LED. My slides are not moving. Maybe I'll have to unshare and log in if you don't mind. Are you able to see the presentation now of the OCT? So this is the post rotablation OCT. You could see in the LED there is a very, very circumferential, deep and dense calcification which is cut. And you will appreciate in the mid LED there is a 360-degree heavy and thick calcium which is continuing up to the proximal LED with almost a very, very dense calcification. So following this, the OCT of the circumflex was done, which also showed a 270-degree circumferential, near circumferential calcium with a calcific nodule in the ostium of the circumflex, and which was also projecting into the polygon of confluence close to the left main. And you would see that subsequent to the rotablation and the shockwave lithotripsy, a drug-eluting balloon was delivered to the distal LED, which was a small vessel of 2 mm, and approximately a 275 to 36 drug-eluting balloon to the LED was done. And thereafter, a field XT wire was placed in the circumflex, and dilatation was done as a pre-dilatation balloon. And this was also treated with 3 into 12 intravascular shockwave lithotripsy balloon to the mid and proximal circumflex, and also to the ostium of the circumflex into the left main, and finally from left main into the LED with a 3 into 12 shockwave balloon. And you would all know that the post shockwave, the images of the OCT showed a well prepared calcified plaque which is cut in multiple locations, and you can see the fractures and how the thick calcified plaque has been really well prepared. And this is the circumflex again showed a well prepared and broken fractured calcium. Subsequent to that, by a Kueller technique, a 3 into 28 drug-eluting balloon was delivered from left main to the mid circumflex, and this was optimized with a 3 into 3.5 NC balloon in the proximal segment of the left main to the circumflex, and then a 3.5 into 23 from left main to proximal LED was delivered by a Kueller technique, and final kissing balloon and optimization of the overlapping stent in the proximal LED was done. And you would see that these are the images of the final check angiogram, which showed a well optimized left main bifurcation, proximal circumflex, proximal to mid LED and distal LED after the successful rotor shockwave complex PCI. And these are the images post stenting by OCT, which shows a well opposed stent in the mid LED, proximal LED, in the circumflex, as well as the left main, which are MSA of 12.6 square millimeter. And this patient was taken up for the right side PCI after 36 hours after well hydration. And again, the rotor extra support guide wire could not cross, and a field XT was used to cross, and a 0.85 Nick nano balloon was used here to dilate the Titus portion and exchange the fielder XT with a caravel placed there, and the rotor extra support was delivered. Subsequently, rotablation was done from the ostium of the RCA to the mid RCA with a 1.25 rotablation with a Judkins JR 3.5 guide catheter through a right radial access approach, and post rotor check showed no dissection, flap or perforation, and reasonable luminal gain. Thereafter, I could not deliver the intravascular lithotripsy balloon, and therefore a plain NC balloon, non-compliant balloon, was used to dilate the tightest mid RCA portion, and subsequent to that, a 2.5 shockwave lithotripsy balloon was used. You could see the waist giving way at the tight calcium as a shelf of calcium you could see in the proximal RCA. Subsequently, the intravascular lithotripsy balloon ruptured after 4 cycles, and then I used a 2.5 into 10 mm flextome cutting balloon, which you could see that it has given way the plaque at the calcified plaque at the proximal RCA. And post IVL and cutting balloon and shockwave lithotripsy, you could see a significant luminal gain from what appeared to be a very, very diffuse vessels. And these are the OCT images of the right coronary artery, which again shows a circumferential, dense and deep calcium, which is cracked by the OCT as well as by the flexdome cutting balloon and also the shockwave lithotripsy and rotablation. The calcium thickness was almost 1200 microns. And despite all these preparations, the drug-eluting stent would not cross, and I required a guide extension catheter to deliver. You could see the guide extension catheter deep throated into the mid RCA, and that was delivering the one of the stents in the mid RCA, which is 2.75 into 36, and then approximately 2.75 into 40 mm overlapping, and then post dilatation of the overlapping sizes was done, and the proximal RCA was optimized with a 3O NC balloon. These are the final images of the OCT of the RCA post stenting, which shows a well opposed stent and a stent luminal MSA of 7.69 square millimeters, well expanded, well opposed stent in a complex. So these are the images of what we started with the right coronary artery and what appeared at the end of the procedure, a well reconstructed vessel from what appeared to be a non-revascularizable vessels. Most of the OCT images were done with the saline, and both stages of CHIP PCI were done through the right radial approach. For the stage 1, the contrast volume was 75 ml, and for the stage 2, the contrast volume was 45 ml with a Visipac contrast. So these are some of the recollecting images of the left main LAD and the post PCI. You could see a well optimized result. So this patient could achieve a complete revascularization CHIP PCI transradially for a no option and surgically rejected. The patient was discharged to home with no contrast induced acute kidney injury in 4 days time. We know that the IVUS as well as the OCT images definitely distinctly improves the stent apposition. The MLD, the morphology, the length and diameter, understanding the plaque modification techniques, stenting and post dilatation, finally leading to MAX or the medial check for the medial dissection, apposition and expansion, which is the new concept evolving in an image guided PCI from MLD to MAX, and that was amply illustrated in this case. So this patient with a complex CHIP PCI, the imaging and rotablation with the lithotripsy was a great leap and a boon to engage a high-risk CHIP PCI for a successful procedural outcome. And probably with these evolving technologies and application, we can offer an option for what was considered as a no-option coronary artery disease. I would be delighted to address any of your queries in your mind and regarding the transradial PCI. And I've been using a transradial PCI in almost 96% of my cases for the last 15 years, regardless of the complexity of the cases. Thank you for the opportunity to address your August gathering.